Health. I'm Dr. Anthony Gonzalez, and we're here again today to talk to you about another health issue. You may not know, but January is Cervical Health Month. And the cervical health we're talking about is obviously women's health. So we're talking to half of our viewers about cervical health and making sure that their cervix and their gynecological organs are healthy. Of course, our men have wives, they have mothers, they have sisters. So it's important for our men as well. And so to talk to us about the cervix and women's health, we have Dr. John Diaz with us today. Dr. John Diaz is a gynecologic oncologist, means that he's a gynecologist, but he deals with these organs that the women have in their pelvis, and he operates on them and he gives them the care specifically and especially when they have cancer. Dr. John Diaz is with us today, and he is from Baptist Health and the Miami Cancer Institute. John, welcome.
Tony, thanks so much for having me. I appreciate it.
Oh, my pleasure. So why don't you tell us a little bit about yourself, John? Tell us a little bit about you, where you're from, and what you do.
Yeah. So I was born and reared in Miami. I attended Columbus High School, so I'm a local kid. Went here to Miami for undergrad, medical school. I went to New York at Sloan Kettering to do my fellowship in oncology, and then came back to Miami. This is my community. This is the place that I love. So I'm a G1 oncologist, which a lot of people ask me at a cocktail party, well, what does that do? Do you deliver babies? No, I haven't delivered babies in over 14 years. And so what I do is I take care of women who have problems either in the uterus, the ovaries. Also with oncology, we're talking about cancers from there. And if they require surgery, then I perform those surgeries. And if they need chemotherapy afterwards, then I give them the chemotherapy for that. Part of my practice is also taking care of benign diseases like fibroids and things like that, and also abnormal pap smears we're going to talk about a little bit today.
All righty. So, of course, it's Cervical Health Month, and we're talking about women's health. And so what is the cervix?
Yeah. So the cervix is the end of the uterus, and it's what protrudes into the vagina, and it's kind of like the doorway between the vagina and the uterine cavity. And it's what allows sperm to pass through for fertilization, okay? It's also what keeps the baby in place during a pregnancy. And when the time comes up in the 9 months, the cervix is what dilates and allows the baby to pass through into the birth canal for birth. When women aren't pregnant, it's what kind of helps keep some of the bad things out of the uterus.
And the cervix is that portion when you hear about a pap smear, that's what they go in and take a biopsy of or a scraping of?
Correct. The cervix is where often you could develop cervical cancer or precancerous lesions. And cervical cancer screening is performing a pap smear of the cervix, where you, like you said, you take a little scraping of that, you look at those cells and look for any abnormalities. Now, we've kind of come a long way from that. We now look at HPV infections and a combination of both pap smears and HPV infections to screen women for cervical cancer.
And what is HPV infection?
So HPV is a very common virus, and it's spread by skin-to-skin contact, most commonly through sexual contact. And there are many different types of HPV. The ones we worry about most are what we call high-risk HPV subtypes, like 16 and 18, which are responsible for over 70% of cervical cancers. They're also responsible for head and neck cancers and anogenital cancers. So this is something that we try and identify and, if possible, prevent. There are other subtypes, too, that can lead to cervical cancer. And there's some benign subtypes, in other words, that don't lead to cancer, but can lead to anogenital warts, like HPV 6 and 10. And this, although not cancerous, can be really psychologically and even physically traumatic as a treatment for this. So these different types of HPVs can have impacts on women and men.
So when a woman goes and gets checked, you guys are checking for the HPV as well, and it's checked in the cervix? Is that what's happening?
So you can. So there are different types of ways to screen for cervical cancer. One of the screenings is the traditional pap smear that we used to do. Another screening now is looking solely for the HPV high-risk subtypes, okay? And actually the new guidelines for 2020 from the American Cancer Society talked about using what's called primary HPV screening. So instead of doing the pap smear first and then looking for HPV and abnormal pap smears, you start with the HPV first and then go back and look at the pap smears. And there's also what's called co-testing, where you do both the pap smear and the HPV and use that combination to determine what's a woman's risk and when does she need to have her continued follow-up, or does she need additional investigation for any of these abnormalities that are found.
Wow, that's very interesting. Okay, so you told us a little bit about the cervix. You told us it's the end of the uterus. What it does, it obviously is the gateway, and it also helps with pregnancy. So how does a woman take care of her cervix?
Yeah. The most important way to take care of your cervix is just routine GYN care. Be sure to see your gynecologist every year. And what they'll do at these GYN visits, they'll do an inspection of the cervix, which is to look at it for any abnormalities. They'll do a palpation of the cervix, make sure that it feels normal. And then, if appropriate, they'll do a pap smear. And the reason I say if appropriate is it used to be every year you need to get your pap smear. And that's when we did the old school pap smears. Now that we've introduced HPV testing, depending on your age and other risk factors, you may not necessarily testing. And depends on your age, other risk factors, and what your previous pap smear history is. So although you may not need a pap smear every year, you need to see your gynecologist every year.
Now, one of the things I learned, obviously, as well, is that even if you've had a hysterectomy and you've had your cervix and your uterus removed, you still need to see your gynecologist every year. Is that right?
You do, and that's kind of a misconception. Women feel, well, if I have a hysterectomy, I no longer need to see my gynecologist, and that's not true. We still need to inspect the vagina. We still need to inspect the outside area, which is called the vulva, because even though you may not have a uterus or may not have a cervix, there may be still other areas that can develop there. And if you still have your ovaries in place, you need to be evaluated for any possible ovarian masses. So even if you had a hysterectomy, you still need to see your gynecologist.
Yeah.
And
So
if you had a hysterectomy and you had a history of abnormal pap smears, then you still need to get your pap smear done of the top of the vagina, what's called the vaginal cuff.
So every woman should see their gynecologist every year. That's for sure.
Every year.
All righty. That's great. Okay. So the cancer, everybody's concerned about the cancer, and we're worried about cervical cancer. So how does a woman or somebody listening to us or watching us today ensure that they don't have cervical cancer, or how do they catch that cervical cancer early?
Yeah. So I think before we jump to cervical cancer, Tony, I want to talk about the HPV vaccine, which will help prevent cervical cancer.
Okay.
So HPV vaccination is, now we're all common with vaccines thanks to COVID, is a vaccination that prevents both men and women from developing these diseases as a result of HPV. And so currently there's a 9-valent vaccine that's available in the United States, and it's recommended for both men and women. Ideally, you'd like to get this vaccine before you become sexually active or exposed to HPV. So the recommendations really are by ages 11 and 12 that both girls and boys should receive this vaccination. And the vaccine helps prevent against the 9 most common HPVs that we see in the United States, including those that can cause genital warts. I have 2 boys, and they've been vaccinated. And again, the idea is for women to prevent cervical cancer, as well as genital warts, and for men to prevent in the future other HPV-related cancers, which could be head and neck cancers, also genital warts, and the idea of herd immunity, which again, I know because of COVID now, we're all familiar with that concept. So if you get the vaccine before 15 years of age, it just requires 2 injections. If you get it after 15 years of age, it requires 3 injections. And initially it was approved to the age of 26, but the FDA recently expanded that to 45. So I'll have women that I see in my office who have an abnormal pap smear, or they may even have one type of HPV infection. But if they're under the age of 45, I discuss with them the potential benefits of still receiving the vaccine. So again, both boys and girls should be offered this vaccination, ideally before they start sexual activity.
And so why don't we vaccinate those over 45?
Yeah, so that's a great question. And for a while, we weren't allowed to vaccinate those over 26. The thought being is that as you get older, you've already been exposed to HPV. And if you're going to develop one of these diseases, remember the United States, average age of diagnosis of cervical cancer in women are in their mid-30s to early 40s. So you're less likely as you get older to have new exposures to HPV. And so right now we don't have the data to recommend it, but there may be some time in the future where, in fact, yes, we'll allow this for patients that are older than that.
All right. So what I've understood so far in the few minutes I've been with you is, of course, you have to see your gynecologist, get the routine care that you need yearly. And then kids and young adults need to be vaccinated, HPV vaccine. And so those are important notes to take from our conversation thus far. So now we move into cervical cancer, or are there other conditions that can occur of the cervix that women should be aware of?
Yeah. So thankfully, through vaccination, we've really dropped the number of women that we're seeing now who are entering adulthood with developing of precancerous or HPV-related lesions on their cervix. So vaccine in the 10 years it's been out has already had an impact here in the United States. What we're doing when we do our pap smear is we're looking for any abnormal cells or any precursor cells that may eventually develop into cervical cancer. Thanks to the screening programs we have in the United States and most of the developed world, cervical cancer really is not very common. There are only about 12,000 cases a year. There are about another 6,000 cases related to the vagina and the vulva that are HPV related. So the idea is if you have your pap smear and we find an abnormality, then that can be worked up. Oftentimes it requires what's called a colposcopy. So we look at the cervix with like a microscope, and if we see anything abnormal, we'll take a biopsy. And the whole idea here is to catch a lesion while it's still undergoing some changes, but hasn't yet resulted in a cancer. And the thought is from time of high-risk HPV exposure to developing a cervical cancer is about 10 years. So we have a window where we can catch this disease. And it's why it's so important for women to routinely see their gynecologist and undergo routine cervical cancer screening. So we can intervene before we get to that cervical cancer.
So then we are starting with the precancerous lesions. If a woman has a precancerous lesion or abnormal cell and you guys do that colposcopy and you do a biopsy, what needs to be done for them?
Yeah. So it depends what the biopsy shows. If it's an early lesion, a lot of times the body will take care of this. Again, most of us have been exposed to HPV, but our body is able to eliminate this virus, suppress it, and any abnormal changes that happen, the body's able to heal. It's those women that have a persistent high-risk HPV infection or whose body's unable to heal this lesion, and it progresses from a precursor lesion, what we call like a level 1, to eventually a precursor level 3 lesion or cervical cancer. So if we catch it, depends on what level it is. Sometimes you need to do an excisional biopsy. Sometimes you can freeze or ablate the cervix. And in some women, we need to do a hysterectomy to prevent this lesion from progressing to something more serious.
All right. So once somebody has cervical cancer and they present to you with cervical cancer, they went to their usual gynecologist and the gynecologist found that there was cervical cancer. What is the typical treatment options for a woman with cervical cancer?
Yeah. So the first thing is, where are they in their fertility? In the past, we diagnosed cervical cancer in someone who's 29 years old. They may have already had 4 kids by then and really done with childbearing. But as women continue to pursue careers, medicine, law, they're putting off starting their families. And many women who in the past were diagnosed in their early 30s and were done with their families, and sometimes haven't even started their family planning. So it really depends on where they are with fertility. And if fertility is still an issue, we do have options for women where we can treat their cervical cancer, but maintain their fertility.
So what options do exist? So let's say you were telling me already, and you told us that cervical cancer comes in the 30s and 40s. And so somebody's 35 or 39 years old and still wants to have a kid, and they've been diagnosed with, let's say, cervical cancer. What would be their options?
Yeah. So the traditional treatment for cervical cancer is a hysterectomy, which would be removing the cervix with the cancer and the uterus. But that's not going to leave you with fertility options, or at least not where you can carry a child. So something we developed in New York was what's called a trachelectomy, which is where you remove the cervix with the cancer, but leave the uterus behind. And we first described this about 10 years ago. And what we saw was that by removing the cervix with the cancer, but leaving the uterus behind, women who were appropriately selected still had great oncologic outcomes. In other words, they were cancer-free, but they were also able to carry a pregnancy. And about 70% of women who undergo that procedure are able to get pregnant. Now, it's important to get this done at a specialized center where we partner with not only the surgeons, but the infertility physicians and high-risk maternal health physicians.
So you told us already that the cervix is holds the baby during a pregnancy. If you take out that cervix, and I know enough about this as a doctor, that the baby, you could lose the baby. So how is that? How did you guys solve that problem?
Yeah. So when we first started, we would remove the entirety of the cervix. The cervix, depending on the woman, is about 4 centimeters long. And what we found was if you removed most of the cervix, but left behind about 10 millimeters of cervix, that was enough to reinforce the uterus and help prevent these preterm deliveries. We also put a cerclage at the time of the surgery to help prevent that. And again, it really was patient-driven that we made this change in our management. Patients weren't happy with the option of, we're going to take your uterus away. And oncologically, it didn't make sense. That part was a healthy organ. It was the cervix that was impacted. And so that was a big change in the management. Now, again, that's for select patients who want future fertility and have the appropriate cervical cancer. Most women diagnosed with this undergo what's called a radical hysterectomy, which is the traditional surgical approach, which is removing the cervix with the cancer as well as the uterus and the surrounding tissue.
Now you mentioned cerclage. For our viewers, explain to them what a cerclage is.
So cerclage is a stitch that we put around the cervix to kind of reinforce the cervix and help support it to keep it closed. Because we did realize that in these women who underwent these trachelectomies, there was an increased risk of preterm deliveries. Thankfully, with our partners in the NICU, who do a great job with these babies, babies who are born, after 34 weeks really do very, very well. So if they're born a little bit early, they're really very little sequela to these babies. And women with this cervical cancer are able to take home a live genetic baby.
Wow, that's good to hear. So obviously, if you're young and you're still fertile, and it, of course, a selected cancer, you can have this removal of the cervix. So we're removing 75% of the cervix. Now, if the woman has already had 3-4 kids, had a tubal ligation, not interested in childbearing, you already mentioned, hysterectomy, radical hysterectomy. So tell us, what is a radical hysterectomy versus a regular hysterectomy, and how is that done today?
Yeah. So a hysterectomy, like what we would have for, let's say, fibroids or abnormal bleeding, is where you remove the uterus and the cervix. And this can be done minimally invasively, most commonly done robotically. A radical hysterectomy is an oncologic procedure. So you want basic surgical oncology principles, which is you want to take the tissue around the affected area. So you'll take not only the cervix, but you'll take a little bit of the vagina, and you'll take a little bit of the area around the cervix, which is called the parametria. And the reason behind this is you want to get negative margins. And that's the difference. So it's a little bit more complex, requires a special skill set. So you need to be done by someone like myself, a G1 oncologist. And this, again, for early stage women is the preferred treatment choice. Unfortunately, many women present with advanced cervical cancer, where it's either a large lesion, it's invading other organs, and those patients, surgery really isn't an option, and they get treated with definitive radiation therapy.
Wow. So they'll get radiation and they won't have surgery.
Correct. So those women are get treated solely with radiation. We give them a little bit of chemotherapy just to make the radiation work better, but the primary treatment for them is radiation therapy. And this is really a difficult concept for patients and physicians to grasp. A lot of times my patients will say, well, now that I've had my radiation, when are you going to do my hysterectomy? And I have to explain to them, no, you had the appropriate treatment. And in fact, we did a study looking at this where we looked at doing what's called a completion hysterectomy. So they got their upfront radiation therapy, then they had their hysterectomy. And what we found was by doing the hysterectomy, it really didn't improve their outcomes. In fact, these women had a lot more complications following that. So it's not recommended. And I think that's one of the hardest things sometimes in counseling patients, this idea that what was unhealthy, my cervix, you're going to leave in my body. And that's really a challenging thing in dealing with patients, explaining the concept of that.
Yeah, patients all the time, and even in my practice and what I do, you tell them they have to go to chemotherapy first, and they're like, no, let's get it out today, like right now. And I go, no, the outcomes are much better. So, if they're in their mind, cut everything out, and you're not cutting it out, then they have some anxiety with that. So one thing you didn't mention in hysterectomy, whether it be I guess a simple hysterectomy or a radical hysterectomy, is the ovaries. What about the ovaries? Do they have to come out as well?
So it depends on the age and the stage, right? So ovaries are what produce your estrogen. It's what keeps women out of menopause. And although I'm an oncologist, I'm very conservative when it comes to the ovaries. We used to think that, if you're going to have hysterectomy, let's remove your ovaries and avoid ovarian cancer. The reality is ovarian cancer is a very uncommon cancer. There are only about 22,000 cases a year in the United States. And a woman's risk, if she doesn't have a family history and doesn't have a genetic mutation, of developing ovarian cancer is only about 1.7%. So if you're going to have an elective hysterectomy, fibroids, even if cervical cancer, and it seems an early stage, there's a benefit to keeping your ovaries. That benefit, it helps protect your heart, helps protect your bones. And remember, the number one killer of women in the United States is not breast cancer, it's not cervical cancer, it's heart disease.
Yeah.
And so it's very important for women to understand that. And when I speak, I often have a slide that says, in Miami, we have a surgery called Sácamelo Todo. And again, my patients, the idea of just take my ovaries out. And it takes a lot of counseling for them to understand that studies have shown by keeping your ovaries, you actually live longer. So it's really shared decision-making between us and the patient, understanding what are the benefits of your ovaries to your heart, to your bones, and then what are your risks of developing ovarian cancer, which again is a serious cancer when it happens. 85% of women present with an advanced stage disease, but your average risk is only about 1.6%. So if you're still early on, or even in menopause, there's benefit to keeping your ovaries up until the age of 60. It's really a shared decision-making and making sure they understand what are the benefits to their heart in particular, and what are the heart risk factors? Are they overweight? Do they not like to exercise? Do they have a family history of heart disease? All these things factor into making that decision. So it's not an easy yes or no question. It really needs to be tailored to the patient.
Good. All right. So we've learned that you may have to have your uterus removed, maybe not have it if it's early on. We learned that the ovaries really don't have to come out. Now we talked about all this surgery and you mentioned robotic surgery, and that's something we have in common in that we both do robotic surgery. Tell our viewers a little bit about how this is done robotically and what type of recovery are patients expected to see.
Yeah. So robotic surgery has really changed the management in GYN. Robotic surgery, as you know, was early uptake with the urology service, and GYN wasn't far behind. In the past, if you had a hysterectomy, you'd stay in the hospital 3 to 5 days, and it was 4 to 6 weeks recovery time. Nowadays, with robotic surgery, our patients go home that very same day. Patients usually driving 7 to 10 days later. And most patients are back to work within 2 to 3 weeks, depending on, again, what other procedure they had at the time of surgery. So it's really revolutionized the way we treat women. Now, not every woman is a candidate for robotic surgery, and not every disease can be treated robotically. But for women who are being treated for fibroids or abnormal bleeding, absolutely robotic surgery is the way to go. And it's for women who have endometrial cancer, which we know what I'm talking about today. Many of these women are overweight, which is one of the risk factors of endometrial cancer. And I remember when I was a fellow, we'd start the morning at 4:30 in the morning to pack all these open wounds from these women who got infected. Now with robotics, they go home the same day. There's no wound infection. Patients do great. I did a patient last week, and I saw her in clinic this week, BMI of 62. Wow. She did great. Went home the same day, feels great. She's going back to work next week. So robotics has really revolutionized the way we operate in GYN and GYN oncology.
Yeah, for our viewers, BMI 62 means that the patient's about 200 pounds overweight. So that is a very high BMI. Normal BMI is, up to 25, maybe 30 if you're overweight. And, we do weight loss surgery on patients who are BMIs of 40. So he's doing gynecological surgery, removing uterus on somebody with a BMI of 60. So that's obviously a high-risk patient and a huge undertaking. So congrats on that. Sooner or later, I may have to operate on her.